Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is entitled Management of Peripheral Arterial Disease in Diabetic Patients. And our distinguished guest is my colleague Manesh Patel, Assistant Professor of Medicine here at Duke, and an interventional cardiologist. Manesh, thanks for joining us.
Thanks for having me, Sunil.
So, Manesh, I was rounding the other day on the inpatient cardiology service, and we encountered a 74-year-old diabetic patient who had been admitted to the hospital with an acute coronary syndrome. And during the evaluation phase, she did admit to having some cramping in her legs when she walked. And interestingly, this has been something that had been going on for a while, and she had commented about that to some of her previous physicians, and actually got the advice, she said, every time I walk to the mailbox, my legs start cramping, and the advice she got was, well, don't walk to your mailbox anymore. And we were obviously suspicious that a lot of this represented peripheral arterial disease, given her other risk factors. So tell us a little bit about how to manage PAD in patients with diabetes.
Thanks, Sunil, and hopefully my discussion here today will get us through some of the issues around your patient and how we think about peripheral arterial disease. First, these are my relevant disclosures. And let me just start off the presentation by showing you a couple of what I find to be very informative slides. This slide here is the state amputations by county for lower extremity non-traumatic amputations in 2006. And what we found most interesting about this map in North Carolina is that obviously you can look across the state and find out that there are different rates, sometimes 3 times higher rates of amputations in patients, mostly diabetic patients in our own state. And if you take it a step further and say, how about the United States? And a lot like the rest of things with hypertension, stroke, tobacco use, many of the risk factors, diabetes, obesity, we're in the amputation belt here in North Carolina. And along with your patient who probably has claudication, amputations, ulcers, and diabetic patients, this is the enemy. How do we prevent these events in these patients? So most of what I'll be talking about here today, and hopefully we'll go over, comes from this document endorsed by all of our societies, really, the American Heart Association, the American College of Cardiology, surgeons, interventional radiologists, and vascular societies on guidelines for management. And I hope if we come away from this talk with any real 2 issues is take-home points are what should we be looking for in our patients, who's at risk for peripheral arterial disease in our diabetic patients, and then how do we manage it? So a lot of it will come from this. The first you might say is how do you define an at-risk population for peripheral arterial disease? And as you already alluded, diabetic patients are one of the key factors for at-risk. The second is patients from 50 to 69 that smoke and have diabetes. And finally, people over 70. And you may ask, where does the guidelines get this data from? Well, many have seen this slide. It's from the Partners study in Harvard. And what they did was pretty interesting. They took roughly 7,000 patients at their primary care clinics, cardiology clinics, and they took everyone over 70, anyone between 50 and 70 that had diabetes or tobacco use, and they did an ABI, just looking for peripheral arterial disease. And interesting, as you see on the slide, roughly a third, or 29%, had peripheral arterial disease. Half of them, shown there in red, had also cardiovascular disease, and 44% just had peripheral arterial disease. But maybe what was most astounding in this group was that only 50% of the patients' doctors knew they had peripheral arterial disease. So a lot like the patient you presented to me may complain of claudication. It's not always same symptoms, buttock pain, calf pain. And one of the hardest things to do with these patients is to identify, is it sciatica, is it their muscles, is it the bone, peripheral neuropathy in diabetics, or is it peripheral arterial disease?
So Manesh, having said that, and you may talk about this a little bit later, so I don't want to jump the gun a little bit, but have we approached the point where perhaps in the primary care physician's offices the ABI should be part of the routine evaluation for vascular disease?
I'll show you some recommendations from the American Diabetic Association. They're certainly a little bit more aggressive than the United States Preventive Task Force. But the ABI has been proposed, and I'll show you some data here in a second, to be a screening test for vascular disease and for peripheral vascular disease. I would say, does it meet the criteria? Is it cheap? About $7. Can I do it in your office or my office? A blood pressure in the arm and the leg? Almost all of us can do that. Is it predictive? Well, I'll show you data. I would argue it's more predictive than CRP and a lot of the other things that we currently advocate. So, yeah, obviously I'm a little biased as a peripheral doctor, but I think the ABI is a very important test. This slide here shows you some of the risk factors for peripheral arterial disease. As you can see, a lot like coronary disease, there's the same sort of risk factors. Tobacco use or smoking. Diabetes is the second risk factor with maybe the strongest association along with tobacco use. Then hypertension, hypercholesterolemia. And you'll see alcohol, just like with coronary disease, some moderate alcohol may go the other direction. Interestingly, if you think about PAD, it's much stronger with smoking or diabetes. In fact, we can go through an entire vascular clinic and find no patients with vascular disease that don't have either diabetes or tobacco use. So it's prevalent, and it's one of the risk factors that you're always going to look for. Well, this is what I call the big three: peripheral arterial disease, MI, and stroke. And just like your patient who was in the hospital for a coronary event, peripheral arterial disease, in fact, puts you at risk for higher rates of other vascular disease. Our patients understand that. I often say, the problem with your arteries is not just to your legs or your heart. It obviously can be to your brain, too. But you can see that the diagnosis of peripheral arterial disease puts you at a 4 times increased rate of MI and coronary heart disease, and in fact 2 to 3 times rate for TIAs and stroke. So one of the things we have to remember for your diabetic patient or any patient with peripheral arterial disease, that our goal is to reduce vascular events. And the title of my talk about SAVE I'll come back to, but we want to, when we think about patients with diabetes or anyone with peripheral arterial diseases, reduce their vascular risk. Well, the guideline recognizes that people show up in different ways. The patient you described was in the hospital. You may have people that are asymptomatic. The screening ABI, as we discussed, the United States Preventive Task Force has yet to endorse that, likely because of cost. They don't understand what to do with the information, much like we don't. Sometimes there need to be larger studies to say, once you screen with an ABI, what should be the management? I would argue that the management is likely aspirin, statin, and a lot of routine secondary prevention. The fact that you have an abnormal ABI should be considered a coronary disease risk equivalent. If you're not asymptomatic, then you might have classic claudication. The patient you described sounds like they had that. Walking to the mailbox, often uphill, calves cramp. Patients say they get really tight. They stop for 30 seconds and they release and get easier. Almost happens every time at a certain distance. It should be important to know that about 30% of patients don't always present with classic claudication. They'll have sort of atypical leg discomfort, and I've found that this is often related to where the stenosis is. Aortoiliac stenoses present in very unusual format. People will have hip pain, buttock pain, because the stenosis is in fact higher in the tree, and so they may stop before their calves hurt because they're having thigh or buttock pain, and it doesn't always resolve or may not always be with activity. Well, critical limb ischemia and acute limb ischemia I won't go into in great length, but you can imagine that, in fact, an ischemic non-healing ulcer, a gangrene, in fact, the diabetic patients on that first slide with ulceration and, unfortunately, amputation, that's really the enemy for patients with peripheral arterial disease. This is one of the hard events that we see in those patients. I showed you the slide. I should tell you that, within your first year after an amputation for these diabetic patients, their mortality is as high as 25 to 30%. So it's not without risk that they get to that stage. So how do you make the diagnosis? We started talking about an ankle brachial index. I think I'll go into a little bit about how you make the diagnosis of peripheral arterial disease and how our diabetic patients and other patients at risk should be evaluated. The guidelines give you this sort of diagnostic criteria. You can do non-invasive imaging, so that's the ankle brachial index with rest and exercise. In our own clinic, we find that that's useful. It's every patient that comes in the door can usually do it. If their symptoms are really good, we'll walk them to. The guidelines represent that this is probably a nice functional way of evaluating them. Duplex ultrasound is another wonderful non-invasive modality where we can see the stenosis or look into areas that might be blocked. And then we have a little bit more of the invasive and non-invasive evaluation, such as the magnetic resonance angiography or CT angio. And the cath lab, as I'll show you some pictures, we have numerous interventional techniques or ways of taking pictures and measuring pressure gradients.
How do you decide on something a little bit more elaborate like an MRI, or perhaps a CT angiogram before going to the cath lab? Is it used mostly to rule out disease? Do you find that it's a helpful adjunct when you get into the cath lab?
That's a great question. I think in the current practice of vascular medicine, the ABI is a starting point, and I would say that's used to rule out disease. Somebody comes to my clinic for evaluation of leg pain. One of the first things I want is an ABI, rest and exercise. If you have a normal exercise ABI, it's unlikely that a significant part of your pain is coming from a vascular problem. I tell patients it's pretty simple. There's a highway from your arm to your leg. There's a blockage somewhere there. The pressure in your leg is going to be lower than your arms, and that should help us. Clearly, patients with subclavian stenosis or other disease are unusual, but the ABI is a screening test. For patients that we want to take to the cath lab, I'll go through sort of our criteria. We usually go through walking, medical treatment for the diabetic patients, risk reduction, and then if we're going to do an invasive procedure, often if their kidney function is not normal or we're trying to stage the procedure, we'll do a non-invasive angiogram. That being said, with the recent problem with NSF or necrotizing systemic fibrosis with MRA or CT angio with the same iodine load, we've gotten more and more accustomed to sometimes doing an exam, ABIs with pressures in multiple areas in the limbs, and then going straight to the lab. So it's a variable on the patient and their risk for the procedure, but I use the non-invasive angiography to sort of stage what we're going to be doing. The other thing is it gives the patient a better understanding of what the day is going to be like and what they're going to expect. So as interesting as this slide looks like, an ABI seems pretty straightforward, but I will say that this is on the cardiovascular boards for the last few years. And one of the things I tell our fellows to remember is that it's not only the pressure in the arm and the leg, but it's the highest pressure in the arm and the highest of the measurable pressures in the leg that form your ABI, with the numbers being that a normal ABI should be between 0.9 and 1.3, and a critical or abnormal ABI is less than 0.4, with sort of mild moderate disease 0.4 to 0.9. That sort of makes sense, and as you know, with gravity and Hill's sign or other physical exam findings, your pressure in the leg should be higher. This is just an example of what MR angiography looks like. You can see that this is a patient who has a fairly focal iliac inflow lesion, and you can see that it's on the left side, and then also down, often as is the case, they have adductor canal disease where the SFA goes into the popliteal. With best you can see here, at least 1 to 2 vessel runoff below the legs, but not clearly 3. This is common in our diabetic patients and our peripheral vascular patients in that they have multi-level disease, aorta disease, something in the SFA, and maybe even outflow disease. Here's a picture of CT. This is a nice example of how CT can sometimes acutely be used to identify somebody who's had a popliteal artery thrombosis. Often this may occur with somebody who has a cyst or has an aneurysm in that area. It's usually with an aneurysm that they may get a thrombosis, but it's not infrequent that somebody with atrial fibrillation or something like that could have an acute thrombosis, and this helps us identify it before we're acutely going to the lab to maybe drip lytics in this patient or in the prior patient decide which level to treat. So, a conclusion of sort of the first part of this talk might be that your diabetic patient was clearly at risk. She has age, diabetes, vascular disease from the coronary tree. If I saw the patient in clinic with some of that leg pain, we would have said, let's do an ABI, maybe do a walking if she could walk, and an ultrasound if we were looking for the level of disease versus treatment modalities. That fits with the guidelines. Most people would say do a resting ABI, maybe with exercise. You can do pulse volume recordings and then decide if you're going to take the patient to the cath lab. If you're taking the patient to the cath lab, you may do non-invasive imaging. Well, what should you do for this patient? And this is one of the hardest things to do in peripheral arterial disease, I would say, is supervised exercise and rehab. In fact, the guidelines say, Class 1A, that if somebody has peripheral arterial disease, the first thing you do is tell the patient to undergo a program of supervised training, and hopefully this helps them walk farther. And in randomized trials, we would say that they've gone through at least 4 to 6 weeks of sessions of 30 to 45 minutes where they're asked to exercise to the maximum pain and see if they can work through it. In fact, they'll stop when it gets to be too much, but then we encourage them to walk farther. We check their blood pressure. We sort of give them some training goals. The big problem with supervised exercise and rehabilitation isn't that it doesn't work. It's that it's, one, not reimbursed. So right now, Medicare and most insurance agencies don't pay for supervised exercise. And even though randomized trial data has shown that it makes people walk and have better performance, much like with heart failure, we might now need to do a larger trial to look for a payment indication in this group. The second is, it's hard to tell someone who comes to your clinic saying, my leg hurts when I walk, and then to say, well, you need to walk more, and not have a way to give that patient controlled environment to do it, and do it with at least, say, a covered modality. We have done studies, and others have done studies, where just writing it on a prescription pad and telling the patient to do it doesn't work. They don't go home. They don't start walking 3 times a week because you've told them to.
How does this work? Now, for perhaps the viewer who's not familiar with the data behind exercise training, is it a angiogenesis phenomenon? Is it conditioning of the muscle? Why does exercise seem to help?
It's a great question that, at least recently, as you know, there's an NIH NHLBI study called Amnesty, led by Dr. Brian Annex, who was here, and others, where we wanted to understand the mechanism of exercise. It's not clear. It's hypothesized that it's through increased release of vascular endothelial growth factor and increased microvascular angiogenesis. In that study, patients underwent supervised exercise with 3 time points of biopsies of their muscles to pathologically look to see if there's higher capillary density, markers for release of the vascular growth factor, or other issues. And it's a fundamental question. How do you understand and know that exercise helps somebody with claudication? And it likely doesn't just relate to the calf muscle. It probably relates to your heart and other vasculature too. My sense is it's probably a set of mechanisms. I believe that the bone marrow is likely your fountain of youth, and hopefully you have cells that can mobilize there. When you become hypoxic in your tissues, you release some of these growth factors, they start to build these vessels and mobilize either active cells or cells that are often circulating as endothelial progenitor cells. That's all of my hypothesis. There's starting to be some data that goes that direction.
From a practical point of view, you brought up a very interesting question, which is how do you sell this to the patient? When you talk to a patient about supervised exercise and you tell them to exercise, what do you tell them about how to walk through the pain? Do you tell them if you keep walking, you'll realize that you'll go further and further every day? At what point should they actually stop walking?
This is a great question, and I think very practical and important. First is, how do you get them to go? What I tell most of my peripheral arterial disease patients and say, it's usually tied with smoking cessation. So first I say, try to cut back on your cigarettes, put the money you were going to spend in a jar and see at the end of the week how much money you're spending on tobacco. That doesn't quite work for everyone, but it starts to work. At Duke, we're fortunate to have Eric Westman and some others that have a tobacco cessation clinic we can refer our patients to. The first thing is to make a business case for stopping smoking. The second is to say, because it's not covered, take those funds. Roughly in Durham County at Durham Regional or other places in community centers, for $20 at the Y, you get a month of walking. They'll actually check their blood pressure, check their heart rate, and give them what I call a walking diary. And what I tend to say is, the first day I want you to try to walk 30 minutes. And every time you feel like you have to stop walking, write down how many laps or where you were when you stopped walking. And simply after that, put your pain scale. Was that a 6 or 7 out of 10? The next day, walk as far as you can for that 20 to 30 minutes again. See where you have to stop. Put your pain scale. It won't change in the first week. But by week 3 to 4, you'd be surprised that people are going a half lap, a quarter lap farther. Remember, in the randomized trial data, people walked 350 to 400 feet longer at the end of 6 weeks. So it's not a dramatic change, but it likely also affects your heart, your vasculature, and in general, you're trying to change behavior. So you're saying, stop smoking, start moving, and see if the $20 you didn't put into tobacco got you to the Y. It's the start of a longer program, but clearly people sometimes when they meet us are very debilitated, like the patient you described, where they may not get into it. My experience has been a quarter of the patients we try to do this go through with this. The rest try but don't quite make it.
So it's a really big quality of life payoff potentially for them.
Hopefully, and hopefully, as you can recognize, it's a longer life issue on what do you do for not just vascular disease but vascular care. Well, what about pharmacotherapy? The good news or bad news for you, depending on how you see this world, for me, this is it. This is all we have, unfortunately. It's cilostazol. There's some agents under study, but cilostazol is the only agent in randomized trial data that's been shown to increase how far you walk. Now, pentoxifylline and others have been studied. Compared to placebo, they don't increase how far you walk. The recommended dose is 100 milligrams twice a day. There's a black box warning, I think mostly by association, but we don't give it to patients with heart failure because it is a phosphodiesterase inhibitor. So I tend to start people at 50 milligrams twice a day and then increase it depending on how they tolerate it, because almost everybody you give 100 milligrams to, they may have some nausea, they'll hear about the package insert, they may give you some symptoms. So I say start 50 twice a day, do it for a couple of weeks with exercise, and then ramp up. Again, this medication in randomized trial data, 24 weeks, makes you walk about 25% farther, 300-400 feet, and sometimes treadmill walking distance goes up. So I think it is, for some patients who don't want to be aggressive about their peripheral arterial disease from an interventional standpoint, trying to get quality of life and want to try the medical exercise format, this is a wonderful try. Again, varied response, and we're open to trying to get everybody through that. Here's sort of a slide from the Annals of Internal Medicine. I know it's sort of busy, but it certainly gives you the idea of medical therapy for peripheral arterial disease. Aspirin on the left, clopidogrel 75 milligrams. Usually this is a vascular disease medication people are recommending. Most of that is based on secondary analyses. Charisma and other studies, as you know, have shown varied responses here. The subgroups in all of those trials with peripheral arterial disease do seem to benefit. Simvastatin, other statins have obviously vascular disease reduction, and many patients with peripheral arterial disease are in those trials. I just spoke to you about cilostazol. Ramipril, at least in the subgroup of the HOPE study, the micro-HOPE study, I had some patients walk farther. So diabetic patients getting Ramipril may have actually had a little bit of a walking distance effect. And as I told you, pentoxifylline, I'm not using in anyone because in RCT data it's not better than placebo. So what about endovascular therapy? You know, much of what I do on a daily basis outside of seeing these patients in clinic is trying to open up the arteries and do what we can in the cath lab. And what do the guidelines say about that? The first thing I'll say is that our criteria for getting into the cath lab and for doing these procedures is changing. The task criteria have moved some from stating you shouldn't try a total occlusion ever to now you might consider total occlusion. So specifically for me in the aortoiliac region, if you get across a total aortoiliac and open it up, the durability is not bad in that region, and aortobifem is now prevented. So there could be places where I think the criteria are moving. But the guidelines, as they state right now, say endovascular procedures are indicated for individuals with vocational or life-limiting claudication, and features suggest that you think you're going to have a symptomatic patient with a reasonable likelihood of having an effect. Now, as the devices outreach how well we do in the cath lab and where the data is, you'll see that I'll show you some lesions where we try to do things more than potentially the guidelines say. Also, they state you should try patients on exercise and pharmacotherapy, and certainly we're in favor of that, if not for just pure lifestyle modification, but obviously for symptom reduction. So I guess the last statement here is the most important. They say there's a very favorable risk-benefit ratio. You should consider doing endovascular treatment. Obviously, that's in the eye of the beholder and what you think you can get done. But aortoiliac occlusive disease, as I stated, is one of the ones they mention where they think there's a benefit. So here's an example of a 50-year-old female with diabetes, hypertension, tobacco use, and on the screen you can see on the left side her right SFA has a focal lesion, a 99 to 100%. That was easy enough to get a balloon and a stent across, and hopefully she gets some at least symptomatic improvement from this. Additionally, it says in the guidelines that endovascular intervention is not indicated if there's no significant pressure gradient across the stenosis. Obviously, that makes sense, and they don't want you to primarily stent anything unless a balloon fails. And that probably speaks to where we are with the device and technologies. So like the 50-year-old lady that I just showed you where we did a stent, or your 78-year-old woman with diabetes and claudication, you might say, well, how would you attack her endovascular disease, Manesh? And maybe for the last 10 minutes here, what I'll do is just go through the armamentarium, the growing armamentarium of devices we have in peripheral arterial disease. It's an exciting time. We have a lot of things that we can do to try to open up arteries. What we need to spend the next few years doing is proving when it's most beneficial and how the devices fit. So on this slide here, you have an approach of endovascular versus surgical approaches. I'll talk some about that. Balloon, I just have cryotherapy on here, but paclitaxel and other coated balloons are in Europe and probably coming to the United States soon. Most of the stents in the periphery are biliary stents, but they're now being approved by the FDA for endovascular intervention. We'll talk about where the DES in the lower extremity is, and then I'll go through atherectomy, both directional, orbital, and others, and laser. So I'll try to take us on a whirlwind tour of some of the devices. Here, cryotherapy. It's in general, as you can see, what cryotherapy is a balloon activation into the periphery where you hope that when you activate the balloon, liquid refrigerant enters the delivery line and then quickly escapes into the balloon and cools the balloon, and then the air goes out so that you cool the balloon rapidly so that when you go up with the balloon, the endothelium gets a quick burst of minus 20 to minus 50 degree temperature. Patients don't traditionally feel it because you don't have you have the vasovasorum, but you don't have a lot of nervous input there. And you hope to stun the cells into sort of phase G2 between mitosis and apoptosis so that they don't replicate. I'll say that there are these types of demonstrations. The total SFA gets cryotherapy, and then at 6 months they bring back for angiograms. Much of the peripheral vascular literature is single-arm studies such as this, where we have 15 patients. It's a good study showing that, in fact, at least in these small number of patients, cryotherapy may work, but we continue to need control groups for many of our studies.
So again, for these therapies like cryoplasty, stenting, what you're trying to do is reduce the risk for restenosis from either a balloon result, similar, I guess, to what we dealt with in the coronary.
It's pretty similar. I'll show you some unique things of periphery. One is you want to open the blockage. So, it's simple things first. You want to reduce the obstruction. You want to have a durable result, and you want to have a limited dissection or contralateral injury. So, we're trying to do the same things. This gives you a sense of the science. This is now a few years old from 2006, but in 2006, 104 patients with intermittent claudication and CLI were randomized to balloon versus stent. And that was the Guidant Absolute Nitinol stent. And that made the New England Journal, because at that time, up to 2006, no one had done a moderate to small size randomized trial looking at endotherapy with either stenting or balloons. And as you might imagine, restenosis was 63% in the balloon arm, but still 37% in the stent arm. So it tells you that even best therapy at that time on duplex ultrasound showed significant restenosis.
So interesting. I mean, you're right. The restenosis rate is still quite high in the stent arm, but almost half of what it was in the balloon arm. Would this impact the guideline recommendation then to be a little bit more aggressive with stenting?
I think we'll see what the guidelines say. I think with the introduction of balloon-covered, drug-coated balloons and stents with drug-coated, platforms, we'll have to see. I think the guidelines are likely going to move for short lesions to be self-expanding stents. And in fact, here's the way stents fail in the periphery, one of the major ways. You can see this sort of person bending their knee, and if you look on the fluoroangiogram here, there are two spots where the stent is failed. There's stent fracture. And the amount of torsion in your lower extremity during everyday wear is one of the main ways stents fracture here. And, you know, I think nitinol stents, which form the self-expanding stents, the nickel titanium alloy that expands at 98 degrees to the preformed size, is wonderful material, and the companies have really improved how they work. But there's still a risk for stent fracture. And in the setting of that, we have things like Sirocco 2, which many have heard about, and others where we had sirolimus-eluting self-expanding nitinol stents. The first in man start into what would DES look like, again with very appealing initial results at 6 months and angiographic and both ultrasound results. But then as we moved forward and started to look, and again small numbers, 20, 26, and 23 in each group, we didn't see a significant change in restenosis. So what was my sort of summary of SFA stenting? The first is now the companies and many of the devices are getting an indication in the lower extremity so that they're testing them in patients with SFAs, and we're starting to get hopefully longer-term follow-up. We likely need a national registry of peripheral arterial disease to just see our practice patterns. But the nitinol, in this case for SFA stenting with the Sirocco, the smart stents, there's implications for stent structure and fracture. The sirolimus-eluting stents and their platform in the SFA initially at 6 months looked good, but at 9 months, 24 months, restenosis wasn't dramatically different. And if you ask me, it's because it's not just restenosis as we think about it, it's stent fracture and mechanical function. Additionally, unlike the coronary where you might have 24 millimeters be a long one, here we have 2 centimeters of stent in the lower extremity, and your opportunity to fail grows significantly depending on how much stent you place. Well, if you do stents, what other things can happen in the lower extremities? Well, this animation might show you what happens often is if you take someone with regular blood flow to their leg, our diabetic patient who over time now starts to get atherosclerosis, unfortunately at the adductor canal and back behind the knee, they form this total occlusion, and then they form collaterals of blood cells getting to their lower extremity. So how do you get across a total occlusion in the lower extremity? Well, these are some of the newer devices that are helping us get across these long total SFAs or behind the knee popliteal occlusions. The first is a catheter you probably know has been around for a while called the Front Runner. It's a peripheral chronic total occlusion catheter. The picture on the screen shows you how it looks compared to an 035 guide wire. It's a lot like a Pac-Man device. It goes into the lesion, and we open it up slowly to open up the cap, which may be the proximal 100% calcified cap, and slowly try to make space to get farther. Obviously, there's other devices that many have used with the subintimal technique, both the Outback and the Pioneer catheters. These are catheters where you can go subintimally, and then based on the position of the catheter with multiple angiograms, or with the Pioneer, in case you have an ultrasound to guide you, you can re-enter the true lumen with a needle and an 014 guide wire. I would say in our lab we probably use this catheter 15, 20 times a year max, because often we can just get back true luminal with regular wire technique. But when you need it, it's very useful, and this slide demonstrates some of it being used in a peripheral total occlusion so that you can do a blunt subintimal dissection across the total and then back in to get across. What about laser? Well, our institution and others have been doing laser for a while. The excimer laser started by Jimmy Chang and others at our institution has been used in the periphery for a while. There's a Biamino technique named after Dr. Biamino where you actually take the laser and just sit on the total occlusion cap without a wire in and slowly turn it on and try to get 1 millimeter, 2 millimeters at a time to break the cap and then rewire. That theme, I think, is going to continue to be evolve as we get RF, forward-looking IVUS, and other catheters into the periphery to get across total occlusions. Any peripheral discussion about getting across occlusions and doing peripheral cases wouldn't be complete without atherectomy. Because of the stent failure rate of 37%, even in the New England Journal trial, the long SFA lesions, there's a lot of interest in doing atherectomy and not leaving anything behind. And as you know, silver hot catheters or sort of directional atherectomy has taken a hold, at least in parts of the country. And I think we've used it a fair bit. And this is an example of how the catheter works. It has a long nose cone. You deliver the catheter, take away some of the plaque with certain runs, and improve the flow. Here's an example of places where you don't want to put stents, the common femoral. SFA profunda here or behind the knee in the popliteal region.
Because of that torsion you're talking about.
Because of the torsion, right? Again, I think if you think about what I call no stent zones, places you don't want to be, the common femoral where your fracture risk, somebody's sitting all day, it's going to be very high. They're bending their knee all day, it's going to be very high. This location here, I would, although we got a great result here for a lot of reasons, I found with our surgical colleagues that this is a pretty easy surgical lesion. Doing a cut down and endorectomizing the common femoral is probably what a lot of people do. Occasionally we tackle this. But someone like this woman, a diabetic woman also with an ulcer and limb salvage. Here you can see we did a front runner catheter to try to break the cap, then did a Silverhawk and achieved a pretty nice result on getting flow back to that extremity. So we'll get more aggressive the more difficult the indication. The last two I'll show you and then I'll stop is this is orbital atherectomy. This is a smaller device, 6 French, where the catheter spins at a certain rate off axis and uses centrifugal force to atherectomize, so that you can imagine that a 1.5 atherectomy burr will get up to 4 millimeters, as you increase the speed. So you can actually get a range of opening depending on how well you increase the speed. The interest in the periphery has been good, but I think the coronary trial is going to be very interesting because as opposed to rotablator where you're occlusive the whole time, this will be at least letting flow by. Finally, there's jet stream pathway, which has wings and aspiration, so it's sort of like a 2-in-1 catheter. It aspirates and atherectomizes at the same time. It also, all of these devices are under study and probably need more data. So here's the sort of conclusions for what I think about diabetic patients with peripheral arterial disease. The first is, should you be screening? That question we discussed. The ADA consensus statement says that a screening ABI should be performed in all patients over 50 with diabetes. Again, USPTF is an agreement here, but I think this is a first statement for diabetic patients. Over 50, an ABI may be very useful. And then second is the significance of PAD. I mean, 10 million people in the United States probably have peripheral arterial disease. Half of them are unrecognized. We actually don't know the incidence. Unfortunately, it has no gender bias. Men and women get it alike. 50% of them are asymptomatic. Disease is directly related to your cardiovascular event rate. If you get critical limb ischemia, either with ulceration that heals or amputation, your 1-year mortality is 25%. It has the same cardiovascular death risk as those established with CAD. And I think the shared risk profile makes any of us that do cardiovascular medicine really be peripheral vascular doctors, because all of our patients that have this disease have coronary disease, and you should think about it as such.
So, Manesh, this is really fascinating because, you know, what you talked about was the sort of spectrum of symptoms, and we've talked about ABI as a screening tool. Is it fair to say that if you're using ABI as a screening tool and you discover someone does have a significant peripheral arterial disease but they're asymptomatic, and you used this phrase earlier, you consider it a coronary heart disease equivalent, the foundation of the therapy should be sort of good secondary prevention for heart disease?
Yeah, I absolutely agree. In fact, the title of the talk, and I sort of will come back to it here, is SAVE. We want to save in North Carolina and the United States, and that's stop amputations and vascular events. And so if you find a patient who has an abnormal ABI, now there's always questions of how abnormal, but if it's not less than 0.4, and the patient is asymptomatic, walking, doing their daily activities, the foundation of the therapy should be aggressive lipid management, aspirin, smoking cessation, good diabetic control. That, I think, you could argue for almost everyone, and very few would argue with you. The next is, what do you do for that patient when they become symptomatic? And I think we walk through that. But the first step should be risk prevention.
And so tell me a little bit about your collaboration with the vascular surgeons. I think that it's, you know, certainly at our institution we've got a terrific relationship. How do you approach patients together? Because one part of this is obviously surgical revascularization, and then the ultimate vascular procedure, which is amputation. We're trying to prevent those types of things. What's your approach in general?
Well, the first thing we're trying to do, and we hope to have this set up even on our larger scale, is to provide a one-stop for patients. So we have a vascular clinic where cardiology and vascular surgery is going to be in the same location. So I think that's step one, because you'd be surprised how many patients in the vascular surgery clinic or on the wards don't have a lipid-lowering agent, an aspirin at times. And they're getting much better, but you can imagine we can add to their care. The second is, what happens often for patients is there's a confusing array of what should I do. I have peripheral arterial disease. Let's say it's symptomatic, whether it's carotid disease, renal disease, lower extremity disease. There are endovascular approaches, there are hybrid approaches, and there are surgical approaches. And what they really want is what's the best approach. One of the things that frees us up at Duke and other universities is that we're on the same team, and there are no models that provide either group with better work or lifetime achievement. So we in the vascular group have a motto that we want to do the fastest, best way to get blood flow to these extremities. And so Each patient that comes in gets an ABI. We approach them for studies. We try to decide if they need to be revascularized, and then we have almost like a tumor board, a quick discussion with the surgeons, either in clinic or every Friday we have case conference and say, this patient, how are you going to revascularize the leg? This May, we're opening up the hybrid room, so we're having ability to do both. What I think is where endovascular procedures are going to be, patients aren't going to care if you're a cardiologist or radiologist or a surgeon. They'll be happy to know that you're an endovascular specialist. And so our hybrid room hopefully will allow patients to get open procedures to get to the SFA if you need to, and then do balloon procedures. We're doing endovascular AAA in our cath lab, and you can imagine that there's a mixture of carotids that are going to go that direction too.
So in the last few minutes here, I want you to project into the future a little bit about a real problem, which is critical limb ischemia and the role of endovascular therapy in the treatment of critical limb ischemia, and how successful is it at preventing amputation?
Well, many would argue that I've been here talking about endovascular therapy, but they're not large trials showing that endovascular therapy does much of anything, and I recognize that. And so as we think about the trials and the devices and the exciting stuff we have, the patient population we should apply it to is critical limb ischemia. I showed you the state map and then the United States map on critical limb ischemia. If you were to think about what is it we could do and what could we measure, I think wound healing and amputation rates are something that would be FDA approved, great for trials, and obviously good for the patients. And so what I think is going to happen with critical limb ischemia, and I don't know if it will, but what I hope is going to happen is that we increase the focus on it. The second is we put in quality metrics. Could you imagine that I was thinking about doing studies on critical limb ischemia, and I talked to Dick McCann, one of our surgeons here, and said, how many amputations do we do at Duke Hospital every year? And he said, I don't know, you have to talk to our amputation coordinator. So we have a full-time FTE set up to do amputation coordination. But we don't have a full-time FTE to do ABIs and angiograms in patients before they get an amputation. So, our goal is to say you should have an arterial evaluation, non-invasive or invasive, before you get an amputation anywhere in the United States. For the first time, the Journal of Vascular Surgery this year reported that the amputation rate in the United States is starting to slowly decrease. It coincides with the endovascular rate going up. I'm not sure they're causative, but it gives you an idea that we need more interest in it.
That's terrific. So lots to look forward to then.
Yeah.
Well, this has been a terrific talk, Manesh. My guest faculty today has been Manesh Patel, one of my colleagues here at Duke. Manesh, thanks for taking some time and presenting some very, very interesting data.
Thanks for having me.
Until next time then, from all of us here at Duke, this is Sunil V saying thanks for joining us and take care.